Good afternoon, everyone. I'm at the International Stroke Conference in Los Angeles, and I'm here with Dr. Nour, who is an interventional neurologist and the director of the UCLA Mobile Stroke Program. So welcome.
Thank you very much. Such a pleasure to be here again with Frazer and our Mobile Stroke Unit.
So we were here in Houston about a year ago, and at that time your ambulance didn't have anything in it. It was all nice and new without everything. So we kind of want to just do a follow-up, maybe some lessons learned, how things went. So tell me when you went live, so how long you've been in operation, and just a little bit about the program.
And this has been such a tremendous experience. Actually, you're right, Laura, last time we had no supplies, we had nothing. And as I'm showing people the rig today, we're saying we are fully ready and operational. This is how we would dispatch today in the field. We have all of our equipment, all of our personnel, the medications and everything we would need, including our telemedicine equipment, including our video monitoring equipment and everything. And so we've learned a lot. We've been live since September 11th in collaboration with Santa Monica Fire, and it's been a tremendous learning experience for us. And we've really been able to respond in the field and help many patients, not only for treatment of acute stroke, whether that be ischemic or hemorrhagic, but also for diagnosing and systems of care routing of patients to the appropriate center. And I think that's a tremendous lesson learned, that before 1 + 1 = 2, we thought this is for IVTPA only, but it really goes beyond and extends beyond all of these measures.
So tell me, so as you said, you're delivering patients to multiple centers. How do you make those sorts of determinations? Because as you said, it used to just be, let's go to the closest center. So how has having this mobile stroke unit changed that?
So in the mobile stroke unit, we have something that any other ambulance can't offer. Not only do we have the clinical assessment of a trained professional, stroke neurologist, but also we have objective and conclusive evidence from CT imaging and CT angiogram imaging, and that cannot be replaced. For example, somebody who has a stroke scale of 10 or 12 and is hemiplegic and may have some aphasia, that could be a seizure, it could be a hemorrhage, or it could be ischemia. And nothing like objectively seeing what that is and routing the patients to appropriate stroke centers of care. And we have a wonderful initiative by LA County for diversion of stroke patients to the highest level of care, because as we all learned from ISC 2017 and all the publications after that, getting patients to the immediate facility where they need to be really impacts their outcomes, meaning that a patient who's a thrombectomy patient should not be sitting at a primary stroke center waiting for an ambulance to transfer for hours while brain cells die. They should go directly to either a thrombectomy capable center or comprehensive center, and we can do that by virtue of the unit, and we've really learned an important lesson about that.
Well, as you said, the triage piece of this is so different because there are so many centers that do a great job. They've got these amazing door-to-needle times, but if the patient doesn't get to that center the first time, sometimes it's much easier to get into a hospital than to get transferred out. So that's great that this is working now and you're doing that and having that success. So you've been operational now, so what's that, 5 months if I can do my math. Tell me something that has gone a lot easier than you expected, something that just sort of fell into place, and then maybe something that surprised you being more difficult than you originally anticipated.
I think that those are really excellent questions. So something that we didn't anticipate going as smoothly, our interaction with our first responders in the field. It was a tremendously, really surprisingly well received with Santa Monica Fire, and we're very grateful for the collaboration with Dr. Wally Garabi, who's the medical director of Santa Monica Fire, and Chief Bill Walker, who's the chief of the Santa Monica Fire Department, and all of the paramedics involved and paramedic captains involved. And really our field interaction has been wonderful. We have learned so much, and being a physician on the other side, receiving side, we only see the patient in the ER and we pound, pound, pound. Hey, what's our last known well time? Give us the run sheet. We need to get out. And now we see how difficult it is of what they do in the field. It is really challenging to sometimes grasp the real story, to sometimes assess the patient. And actually what you realize is that not only do you have to make a decision, but you have to make a split-second decision and live with that for the rest of the day. And that field medicine is very, very different than even emergency medicine or inpatient medicine. And that's something we learned the challenges of, and we're very gratified by the learning experience on both ends. I think the learning is very reciprocal.
And of course, the paramedic pants are really cool. That's what all of the docs have said. You can put everything in them.
That's right. And all of the paramedics make fun of me for wearing tactical steel covered boots, toed boots, but that's okay. I really enjoy them.
So I'm glad that went well, and we've seen other programs. As you said, you had some of the medics here earlier, and they were talking about how they are now better at assessing strokes and taking that awareness to others in their department, and that's fantastic, spreading that. So what about something that you weren't anticipating, a little bit of a hurdle that ended up being a little more difficult or challenging, we'll call it?
That's a very fair question. And what I didn't understand in the field was what was called a dispatcher impression versus provider impression versus final hospital diagnosis. And these three bins are not always concurrent. For example, a dispatcher impression of headache that we received recently turned out to be a subarachnoid hemorrhage in the field, diagnosed in the field by the ambulance, but also the final diagnosis at the hospital. And different departments have different concordance rate between their dispatcher impression and the provider impressions. And we're really learning how difficult it is to assess and to look at that data retrospectively, because part of our interest is really looking at geospatial mapping of the best sitting for as many units as it will take to cover the entirety of LA County, and that means we have to look for stroke hot pockets. Well, how do you distinguish where those are? Well, you can look by hospital admissions, but what were the real stroke dispatches? We don't have a lot of that data. And our colleagues in New York are trying to do a similar study and basically going on dispatcher impression. LA County Fire has done a study where they looked at concordance rate between dispatcher impression and provider impression, and their concordance rate is about 60%, which is terrific. And I think a lot of fire departments haven't done that. And when you are coming from a place like LA County, where there are over 33 jurisdictional areas for coverage, that makes it very difficult. But I think it's our role to synthesize that data and understand much better what's going on.
So explain to us how it works. And different systems have it a different way. If a call comes in and comes into dispatch, where do you pick up along the call? How does that work in your system?
So again, as you said, different systems work in different ways, and the setup we have in Los Angeles County, again, this is the first mobile stroke unit to be live in the state of California, and we're very proud of that. And in our stroke systems, we had to have a good alliance with our stroke systems of care. And as part of that, the LA County EMS, and headed by Dr. Marianne Gausha-Hill, and with the really unwavering support of the County Board of Supervisors, specifically Supervisor Janice Hahn and Supervisor Mark Ridley Thomas, they passed this bill where now we have also financial support from the county, because this is seen as an important county initiative to reduce stroke burden. And now we also became a shared regional resource or mutual aid resource of LA County, so we can theoretically operate within any 911 jurisdictional area in the county, but we started with pairing with select fire departments, and we increased that with time. And so in our partnership with Santa Monica Fire, we are self-attaching the mobile stroke unit to anything that sounds to us neurologic, because of their dispatch system is a bit different. And I would say probably in our live hours in our first few months, dispatcher impression of stroke only came up maybe 5 times. In spite of that, we've treated over 20 patients for transient ischemic attack, for stroke, for subdural hemorrhages, for subarachnoid hemorrhages, and these are called different things. So in Santa Monica, we listen in on the radio, and if it sounds like a neurologic problem, we self-dispatch, we attach ourselves to the emergency response unit. Once we arrive on scene, we assess whether this patient looks neurologic or not, and if it's something we can help with in the mobile stroke unit, we make the decision to admit them in our unit. And the initial response team is now available and free to respond to another call. So in some way, we're helping free up the primary emergency medical response system. And once they're in our unit, our admission procedures are that we get IVs started, we get the patient hooked up to telemetry, we do the basic labs. So we can do INR in our unit in about 10 seconds with a coagu check, with a drop of blood. We can get Chem 8 Plus done, and the Chem 8 Plus will result in about a minute and a half. We can get labs, we can get creatinine, and everything is all set. The next part is the clinical assessment, which is being done concurrently, and clinical decisions are kind of being synthesized at that time. And then the objective assessment of the CT imaging and the decision whether to follow up with a CT angiogram or not, whether to follow up with a CT perfusion or not. And the physician will then synthesize all of that information and make the medical decision making, whether to give clot busting medication, aspirin, Kcentra to reverse hemorrhage, hopefully one day soon Praxabine to reverse Pradaxa related hemorrhage, to reduce the blood pressure in hemorrhages. And then routing is very simple. We are a non-denominational system. We are a county resource. We route patients to the nearest center who is ready and equipped to deal with their level of complexity in terms of neurologic care, and that's done through our base stations, and our paramedic calls in base station, tells them the objective evidence. We have a patient, the NIH stroke scale is so-and-so. The CT shows hemorrhage or no hemorrhage. We gave what treatment. They tell us which hospital to direct towards.
So from everything I've understood, the protocols that you're using out in the field from a paramedic standpoint are exactly what would normally happen, and the same thing in the hospital is what you're doing in the back of this unit. So what do you think from an efficiency standpoint by taking this to the patient? What have you seen from a time standpoint, or just fewer people touching the patient, all of that?
I think our operation is very concise. You take away completely transport time. That's one thing, because we're arriving on scene with the emergency medical responders. We are, from admission into the unit, our goal is always under 15 to 20 minutes from admission into the unit to treatment time or decision for treatment time. We hope to achieve that goal every time, and as our team works more closely together, we hope to even surpass that goal. And I think, you know, that reduction in treatment time makes a huge difference, because afterwards then you can be you know, en route to the hospital, but after the treatment has been initiated.
So I know we had a question that came in through the Facebook page, and one of them was, what about the medics and the personnel in the back? How are they protected from radiation? You have a scanner back here. How does that work?
So great question. Radiation always comes to mind when you see kind of CT technology. So we're very proud to say that we did all of the due diligence in terms of physics testing and looking at the radiation effects, and our physicists in our radiology department at UCLA Health did an extremely diligent job, and part of registering this CT is to submit all of these kind of readings. And they found that the emissions, as Dr. Grada has already shown, emissions from these type of CT scanners, the Ceratome scanner from Samsung Neurologica, are very minimal. And so there are certainly no radiation effects outside of the box. And if somebody is at the end of the box, let's say 6 feet towards the end of the CT, the radiation is also minimal to where they don't have to wear lead. However, out of practice, we all step out of the vehicle for the CT to be done, and our CT technologist, our lead CT technologist, Kevin Brown, he stays in with the patient, you know, make sure the patient's well adjusted. He wears lead for the procedure, and we're able to make sure everybody's safe that way. Funny, because a group from Germany was here, Dr. Audebert, who had the STIMO, you know, first very well-renowned mobile stroke fleet of units, and he said, in Germany, we can't afford to step off the vehicle. Sometimes it's way too cold. Sometimes so in LA, we always step off the vehicle for the CT, but that's a luxury we have, I think.
So talk to me about traffic. So I'm from Houston, and traffic is just part of our daily lives. So how do you find it? If you have to respond to someone, how far out are you going, and where do you house this, and what's kind of the limit to what you can do?
And again, we're operating in two different environments. One is a more metropolitan-based environment in the city of Santa Monica and city of Westwood and surrounding. And in this city, as you may imagine, it's very not only medically dense, but people-wise dense and traffic-wise very dense. And with lights and siren, if we're positioned in a very good central location, within the city of Santa Monica, which the Santa Monica Fire Department has been kind enough to house our vehicle at their training station, Station 4. We sit with their personnel all day, and we are dispatching, and we're really arriving at the same time as the first responders responding also from Santa Monica. We learned very quickly the first day, had this unit been in Westwood, which is, I would say, down the street from Santa Monica relative to other cities, we don't respond on time because they're so efficient. They arrive at the patient within 3 to 5 minutes. They pack up the patients within 3 to 5 minutes. And never do we want a unit like this to delay patient care because it's not always neurologic. They should not wait for our assessment. But we want this unit to only enhance patient care. And in these sites now we have it very well oiled where we're arriving sometimes even before the first respond unit. And in the second site, which is kind of more rural, I wouldn't say rural, it's still metropolitan, but distances are a big issue and traffic is less of an issue, surprisingly. It may take 20 minutes, lights and siren. And in those cases, again, we don't want to delay patient care. All we want to do is enhance patient care with our interaction. And as an additive unit, we only hope to enhance the lives of patients or enrich the lives of patients we are able to arrive to. Again, this is a demonstration project. We're not going to reach everybody in LA County, but through our demonstration of clinical efficacy and cost effectiveness, we hope that this demonstrates a new benchmark for stroke care and it really changes the paradigm of pre-hospital stroke care.
So if you're the patient or the patient's family and this thing shows up and you open the doors, what do you tell folks? Do they kind of say, wait a minute, this doesn't look like a normal ambulance?
The great thing is that we have the rapport and the normal liaison from the emergency first responders, and we try as a team, but also the first responders try as a team to explain what we do. And we say, we're a specialty resource of LA County. Our physicians, our staffing is through UCLA Health. However, we're non-denominational. We will take you to the hospital you are treated at or the nearest hospital, whatever is best for you. We very much honor patient and family requests for transport if it's safe to do so. And then we explain. We say, rather than your loved one going to the hospital, we know the hospital may be a few blocks away and it kind of seems weird that we're sitting in the middle of the street doing this rather than taking you there. But don't worry, we are giving you the best, most revolutionary, most efficient standard of care treatment. And hopefully one day we also offer you novel therapies, novel treatments, novel devices that will advance your care. Because when we speak about the mobile stroke unit, we speak about two paradigms. One is the clinical paradigm where we deliver standard of care treatment faster and set this bar for excellence. And the second one is a research paradigm where this unit can really serve as enhancing the lives of many more stroke patients in the years to follow by looking at novel neuroprotective agents or novel devices where, because we reach patients where we've never seen them before in the pre-hospital setting.
Yeah, some of the other interventional neurologists have said they've seen symptoms that they didn't normally get to see. So the patients present very differently early on in that. So first of all, do we have any questions that have come through when we're doing this?
We have a lot of comments from Frazer friends and EMS.
We have a lot of comments. Okay, well, fantastic.
Saying hello to both of you.
Hello to everybody out there. So one of the things is that you said is, let's see where, we're really trying to push the bounds of what we can do from a technology standpoint and almost bringing the hospital, this is the ultimate return of the house call, right? So if you could look into your crystal ball a few years from now and you could choose what the next piece of technology on here from a stroke standpoint, or maybe something else, maybe in the trauma realm, what do you think it might be?
Again, always excellent questions from Laura, but there are, I think, the answer to your question I can say in two. There are many innovations we can offer on our unit. Again, what about all of these new neuroprotective drugs that are going through trial and so forth? We can really achieve a very different standard by getting to the patient faster before the patient arrives. And the second thing is that devices that may predict large vessel occlusion in the field, and these devices can perhaps be then customized and be in every single ambulance unit rather than just in CT units, and in doing so connect the rest of the paramedic first responder world to a higher level of care, get the patients to where they need to go faster. And I think that's the essence of it. And the second part of the question is that what other possibilities? Trauma units, mobile trauma units. How can we stabilize patients in the field differently than we've ever done before? And the other thing from a cardiology standpoint, mobile ECMO units. And those are really actually already underway in many environments, including one in LA County. And so really it's about looking outside of the box and thinking outside of the box and thinking about how can we restructure our systems of care. We've always done things a certain way and they've worked well. How can we enhance that and bring it up to the next level?
Well, congratulations. It's a lot of fun to have the unit here, and for what you are doing. And as you said, I mean, it's going to be really exciting to sit here a year or 2 years from now and see what technologies have changed, and also to hear the stories of the patients who have been treated on the units and to have these better outcomes. I mean, in some cases, well, the outcomes are really, truly life or death. And so it's amazing what you're doing. Thank you again, and we look forward to talking to you, I said, maybe in Hawaii next year, right?
Thank you very much, and we really appreciate all the support from Frazer, from Samsung, from InTouch. All of these collaborations are what really make our work possible. We are able to bring the hospital to the patient because of all of these folks. And to our team members, Santa Monica Fire, LA County Fire, the County Board of Supervisors, Supervisor Hahn, the Arlene and Henry Gluck Foundation, who made this possible. Without this philanthropic donation and many philanthropic donations around the country, none of these mobile stroke units would be live in the US, because currently we have no funding for it other than special project funding and philanthropy. So we are very honored and humbled to be part of this.
All right, thanks everybody.